Appreciate you coming. Appreciate your attention. I'm glad we got the smaller room. It's always a little disconcerting to sit in a big room and have everyone at the back. Makes me feel lonely. So you're forced to be next to me, which I appreciate. This program is a little bit tied into the joint-specific program in that part of that is interaction between the surgeons and the support staff to help delineate what we expect and our plan for perioperative care so that we have a seamless delivery of top-notch care surrounding joint replacement and, in my case, for shoulder replacement. So this talk is about total shoulder replacements, specifically glenohumeral replacements that aren't reverse replacements, and I can give another talk about reverses at a later time. We'll touch on reverses today, but this is predominantly about the regular total shoulder replacement. So shoulder arthroplasty is an excellent operation in the right patient, in the right setting, when other reasonable alternatives have been exhausted. Other reasonable alternatives include things like anti-inflammatory, steroid shots, physical therapy for stretching and strengthening. But when the brake pad's worn out and the cartilage is gone, exercising that part more isn't going to help usually. Having said that, there are limitations to shoulder replacement, and we don't want to whip these in everyone with shoulder pain. In Mayo Clinic series published in '97, 113 shoulders lasted 83% of the time for 12.2 years with good to excellent pain relief. Significant gains in motion, although motion gains after shoulder replacement are mainly dependent on the function of the cuff. And they tend to survive. Actually, that was the pain relief number. The survivability number is 87 are still in at 15 years in the right setting. That changes if you get them in younger patients, and we'll touch on that as well. So it's a great solution in the right setting, but it's not for everyone, and there are limitations. We can treat a variety of pathology with shoulder replacement. The typical things that cause arthritis in the shoulder are degenerative arthritis or osteoarthritis, inflammatory arthritis, rheumatoid arthritis, avascular necrosis of the femoral head, which is pictured here. And the typical appearance is flattened head and big spurs on avascular necrosis. Fracture dislocations we treat sometimes with either replacements or partial replacements, and that's evolving with the bringing of the reverse into the United States and in the last couple years. Post-traumatic arthritis we can also treat. The diagnoses that do the best with shoulder replacements are osteoarthritis and avascular necrosis that's not post-traumatic. Here's what a typical osteoarthritic looks like. You've got sclerosis, which means dense, hard bone, polished from wear, inferior spurs, no joint space. You can see erosions of the humerus into the glenoid. This can be either concentric, where the arc of the humerus is concentric with the arc of the glenoid, or in this case, eccentric, where you get wear on the back of the glenoid. It's not centered. And there's ramifications of that at surgery and what we need to do for that as well. These people have a lot of pain at night, pain with simple activities of daily living, and eventually, having exhausted conservative measures, in many cases, the shoulder pain and dysfunction becomes unlivable. The option then becomes a shoulder replacement. This is what it looks like at surgery. There's the x-ray. Here's the polished bone. There's no white, smooth, glistening cartilage left, and surrounding the humeral head is this big hypertrophic spur. So that's osteoarthritis, where you have bone formation, osteophytes around the worn-out ball, and it's a hypertrophic bone-forming process. That's different from rheumatoid, where it's an autoimmune disease, inflammatory. You don't get those heaped-up spurs like you saw in the other x-ray. You do get bone-on-bone arthritis, no space on the x-ray for the cartilage, but there's not these big spurs surrounding it. It also has a sort of a thin appearance. It's not sclerotic and white. It's sort of wispy and osteoporotic, and you get these cysts, so that's an inflammatory process. Rheumatoid arthritis falls into the category of inflammatory arthritis. It's the most common, It's an autoimmune disease of a protein in the cartilage. So for me as a surgeon, when I'm replacing that shoulder, I want to make sure I get all the cartilage out. Otherwise, I'm leaving protein behind that can continue the inflammatory process and loosen my prosthesis. So for rheumatoids, we like to do totals rather than partials. Oftentimes, the same inflammatory process that wears away the cartilage here attenuates and causes the cuff to be quite thin and dysfunctional. So in many of these patients, they also have a big atrophied cuff tear. And in that setting, we would do a reverse total shoulder replacement rather than a regular total shoulder replacement. That's why it's important to get the preoperative imaging to decide what operation to do. Here's an example of AVN. We showed this before. AVN's a tough diagnosis to operate on. What happens with avascular necrosis is for some reason the blood supply to the head is lost. The bone then dies. It gets soft and mushy. So essentially what happens, it's like taking your thumb and pushing it into a ping pong ball. That collapses, the head collapses, and then around that you get these hypertrophic osteophytes that actually kind of reach around and grab onto the glenoid. Sometimes at surgery it's difficult even to dislocate this shoulder so you can see the humeral head. You kind of have to chip away these big spurs with curved osteotomes. In many cases, if you start stiff prior to a total shoulder operation, you're going to end up with less motion than you would otherwise. So again, the people that do best after a total shoulder replacement are those that aren't particularly severely stiff. Avascular necrosis is more stiff when it's post-traumatic. Those people do less well than the sicklers or people who've had AVN from a lot of steroid use. We see fracture dislocations a lot with your moped drivers and your dirt bike drivers and alcoholics get hit by cars. Basically, we try to piece those back together with plate and screws if possible. A person's native bone is going to last a lot longer than metal and screws if we can do it. Fractures are classified by how bad they are, how many parts are broken. Basically, a 4-part fracture implies the lesser, greater tuberosity, humeral head, and shaft are all broken apart from each other and displaced. So the worse the fracture, the more likely the head does not have a blood supply and will later go on to AVN. In our people with smoking and renal disease and diabetes and all these comorbidities, even if you piece back the jigsaw puzzle, the likelihood that they'll heal together and then function well is less likely. So with lots of comorbidities and severe fractures, many times as a primary operation in these fractures, we'll do a partial replacement. One indication for doing a partial replacement is this x-ray where you have the double arc sign. That basically means the ball of the head is split in two. So when you piece that together, one piece of that head's going to die from lack of blood supply. They're going to go on to post-traumatic arthritis and not do well with just fixing it with plates and screws. They'll need a second operation to do the prosthesis, so we can do those prostheses primarily. You're in a quandary, though, when you have someone with a bad fracture in their 20s. You want to try to piece those together and hope that it doesn't die, because prostheses, like we saw, only last 15, 20 years. So if you're putting a prosthesis in someone who's 20, you're going to have to replace that every 15, 20 years. So there's some nuances to the diagnosis, the patient setting, the comorbidities that will help us determine what type of operation to do. In our older people, 70 plus with bad fractures, we now are thinking, at least I'm thinking, a good operation for them is a primary reverse total shoulder replacement. Those people are tough to heal the bone pieces together. Once you fix them, the tuberosities tend to melt away. If the tuberosities melt away, the cuff's not attached. If the cuff's not attached, they can't lift their arm. So if you obviate all that, get rid of the need for a rotator cuff and do a reverse primarily in that severe fracture setting, it can sometimes get them a good result with active elevation above the horizon and a painful, stable, a less painful, stable, located shoulder that they can do their activities of daily living with. So it's kind of evolving the indications in fracture, hemi versus reverse total shoulder replacement. That's another talk. But in bad fractures, we tend to replace the proximal humerus either with a hemi in the younger patient or a reverse in the older patient. For the therapist, if we're trying to get little tiny pieces of bone to heal together, we don't want them to really stretch their arm real soon after surgery because we want those pieces to heal first and then worry about getting it stretched out later. Hemi is what we usually use in younger patients with good cuff with bad fractures. Reverses we use in the older patients with bad fractures. Not so bad fractures we try to fix. Here's that devitalized humeral head with what we call a fracture dislocation. The shoulder looks located, except the ball's dislocated out of the joint. There's no blood supply attached to this ball. The blood supply to the ball usually comes from the tuberosities and capsular attachments. So if it looks like this on x-ray, it's broken free. If you piece it together perfectly and get a perfect x-ray, it's going to die. Then you'll have metal rubbing on glenoid. That hurts. That's not good. That's why we go for the partial replacement. Arthritis of instability used to be a little more common a decade ago. Now we do most of our instability operations in our 20-year-old athletes arthroscopically through tiny poke holes. The old style was really tighten things up, and then you get this fixed subluxation of the humerus pushing back on the glenoid. Basically, when a joint's designed to distribute the load evenly between the ball and cup, and then you take that cup and shift it, then you get point loading on the ball. That creates rapid wear and arthritis, and then they can get significant arthritis. So you do an operation in an 18-year-old kid, 20 years later at 38, they've got end-stage osteoarthritis in the shoulder. That can require a shoulder replacement. We don't like to replace the glenoid in young people, so we may just do a partial replacement. We may resurface the glenoid with a biologic material, but this is something we see on occasion, but rarely. There's not been a lot of prospective randomized trials that look at osteoarthritis and compare how people do with shoulder replacements versus hemiarthroplasties. There's one study in the late 90s. I think they only had about 20 to 40 patients, I think 20 in each group. It became clear that the shoulder replacements do a lot better for pain relief and motion. If there was such a difference, they ethically had to stop this study and not deny all those people getting hemis the relief that you'd get from a total shoulder. So if and when, in the right setting, in the right patient, and proper age, you can do a total shoulder, it's better for the patient. Here's a picture of an old person smiling. This is what they look like when they have a successful total shoulder replacement. Got that off the internet. So the glenoid, if something's going to loosen in a shoulder, it typically is the glenoid. Reasons not to replace the glenoid are a young active patient. Any infection, you certainly wouldn't want to do a prosthesis anyway because bacteria attaches to things that are foreign in the body, and you can't eradicate the infection unless you get all the foreign material out. Inadequate bone stock, and I'll show you a slide later that shows bad arthritis, and the cup is so worn down there's just no way to fit a glenoid in that shoulder. You may have to settle then for a hemiarthroplasty. I've done that before, and people have been a lot happier with that than with their painful arthritic shoulder. But it would have been nicer to see them earlier. One of the great pastimes in the aging population in Cleveland County is to live with your pain. So I see people 5 or 6 years after they should have had a shoulder replacement a lot. So it'd be nice to get the word out to say, hey, there is a solution. You don't just have to sit there with the paralyzed flipper. People who have very, very tight shoulders, even after your releases, you don't want to put a plastic cup in there because you'll get that point loading and loosen the glenoid, so we may have to settle for a hemiarthroplasty in that case. And people with dysfunctional cuffs and dysfunctional deltoids, we wouldn't want to do a regular total shoulder. The reverse is a great solution for people with a cuff that doesn't work for whatever reason. It's not attached, it's atrophied, or the nerves to the muscle aren't getting the signal through. If the cuff's not working, but the deltoid's working, the fallback position, the salvage operation is a reverse total shoulder. You guys will have the opportunity to listen to a talk on that in the future if you're interested. This is what cuff tear arthropathy looks like on X-ray. It's The ball is superiorly migrated on the cup. There's no space between the acromion and the glenoid. A normal space here on plain x-ray is 7 millimeters. A person with an intact cuff typically will have a subacromial space 7 millimeters or more on plain x-ray. If that's less, then they usually have a massive cuff tear. When that rides up, if you were to put a regular shoulder in that person, then the metal ball you put in that shoulder would also ride up. Instead of distributing all the forces from the arm transmitted through the shoulder to the thorax to the cup, you transmit all those forces to an edge on the cup, and that'll toggle and loosen that glenoid out of the bone. You get what's called rocking horse glenoid, and they would need that glenoid revision early on. They wouldn't get that 15, 20 years. They'd get the 3 to 5 years. This is what a reverse looks like. It's called a reverse because we take the ball, screw it to the shoulder blade, and put a cup on the arm side. That's the reverse part. You reverse where the ball was, reverse where the cup was. The role in, I don't know what you guys learned in PT school, what I learned in med school was the rotator cuff had all these complex functions: internal rotation for the front muscle, external rotation for the back muscle, abducts for the supraspinatus. That's all true, but what really is true, the rotator cuff main goal is to take the ball of the shoulder and pull it into the glenoid. The shoulder is like a big golf ball on a small golf tee. It's inherently unstable. So the rotator cuff kind of guides that ball into the cup of the glenoid and stabilizes it. And once that's done, the big muscles like the deltoid, the pec, and the lat can move your shoulder around. So the rotator cuff mainly stabilizes the ball in the cup. If that's gone, you get that superior migration from overpull of the deltoid. And the same thing would happen if you replaced it with metal and plastic. You'd still have a dysfunctional shoulder. The reverse sidesteps all that by screwing the ball into the shoulder blade, stabilizing the center of rotation. Now you don't need a rotator cuff to stabilize your shoulder. Now you just need the deltoid to raise it up. So, but the reverse total shoulder is limited too. It doesn't give you that full motion that the regular total shoulder does. So if you can do a regular total shoulder, you should. But if you don't have a cuff, then you can fall back on the reverse. That's a whole other talk, but I touched on it for you guys today. So when we're thinking about shoulder replacement, we do preoperative evaluations. We need to know the condition of the cuff. We need to know how much bone is left on the glenoid, what the version of the glenoid is. So we need to assess the rotator cuff. If there's a massive tear here, we're going to go to the reverse. If there's a small tear, we might think about doing a regular shoulder and just put a stitch in the cuff. If your glenoid looks like this, there's just no bone left to drill in holes, put in cement, put plastic pegs in this, and give yourself a stable glenoid. So we may have to fall back to just a hemiarthroplasty for pain relief and accept the limited motion and a salvage result, essentially. If there's any question about the nerves, we need to know another condition prior to the operation rather than after, because we don't want to sign up for being responsible for that nerve injury that was there before surgery. So sometimes we'll get preoperative EMGs. Okay, it looks like most of you guys have finished your lunch. Now we can get to the gross surgical pictures. I'm just going to touch on this. I don't want to go into too much detail because I would like to continue to be the shoulder surgeon who does these. I don't want you guys doing them out there. So, basically, we start. Typically, I encourage the patients to get an interscaling block. It's safe and effective. It doesn't cause permanent paralysis. It's really no scarier than getting an IV. It's a stick in the skin. They give you relaxing medicine prior to it. Many patients say they don't remember that part anyway. We have a lot of good anesthesiologists now who are excited about doing these and doing more and more of them. Devin McCullough trained in these as well, and he's bringing a lot of his expertise to it. So if we can do the interscaling, I encourage the patient that they get that. The interscaling numbs up your shoulder girdle for 18 hours, plus or minus 6 or 8 hours. So some people get 10 hours, some people get 48 hours. What that means is the arm is numb and weak. It also means they don't have protective sensation for the first night. So for the nurses, I do want you to look in, when you're looking on the patient, look at their hand, look at their arm, make sure it's sitting comfortably in the brace. I have had one patient who had his hand kinked in the sling with the strap coming on the thumb. He didn't feel it or realize it. He did have some skin breakdown over his thumb and had a neuropraxia on the radial side of his thumb, so that his thumb tip was numb. Doesn't sound like a big deal, but that surface right there is the surface you use to feel keys and pick up coins and things. So it's an important area to have protective sensation. So if they get the block, just kind of check on the hand and make sure it's not in a funky position. We place him in the beach chair position. We use the McConnell headrest. The McConnell headrest is a circular piece of metal with a big foam donut on it. We secure their head like that. I've had a few patients come back after surgery and say, everything went great, but my ear's a little bit numb. Well, the nerve branches to this area come right past the mastoid process, and if you have some pressure right over that sensory nerve, it can cause a temporary neuropraxia on that sensory nerve. They always get better. I've never had anyone say that my ear is permanently numb from this operation, but if they have that, it doesn't mean they're having a stroke. It's nothing necessarily to get excited about, and you can assure your patient with confidence that that will get better and go away with time. We use a long deltopectoral approach. I'll show you what that looks like. It's basically a long skin cut. We move the deltoid laterally and the pectoralis medially. The only muscle we really divide during the operation is the subscapularis, and that's important for therapy to know about that we do divide it and sew it back at the end. Many of my osteoarthritics are tight in external rotation. We release the tissue under that muscle so that the muscle is more stretchy and mobile. If you can lengthen that muscle a centimeter, it increases their external rotation 20 degrees for every extra centimeter of lengthening they get of that muscle. This is the gross cadaver picture that's obligatory to each talk. Here's the humeral head. There's the coracoid on the front of, this is a right shoulder. And here's the supraspinatus. Here's the humeral head. There's the biceps tendon. Here's the subscap after we cut it. It's the one muscle we cut and repair during surgery. It can restore some lost external rotation, but it has to be protected post-op. Here's the undersurface of the subscap now looking underneath it. That's the joint capsule that's typically contracted in arthritis. We release the capsule but leave the muscle. There's the axillary nerve close to our work. And once we release it, you can see that muscle can come out a lot further from the scapula, and that'll restore that external rotation once it heals. At the end of the operation, we sew that back. So what that means from a therapy perspective is we don't want too much passive external rotation, or you'll stretch my suture line, dehiss the subscap, and cause instability after the shoulder replacement and frowns. There'll be frowns. We also don't want aggressive or resisted internal rotation, because if you activate that subscap, then the patient's pulling against my repair. We want to protect that for about 4 to 6 weeks. We rarely have to do additional releases to get the external rotation. We take off the bone spurs around the muscle, around the humeral head rather. These are what the bone spurs look like. It's like a friar tuck where you got the bald head here and the hair going all the way around. The hair part would be the big bone spur that comes around the osteoarthritic humeral head. This is showing a jig to make the humeral head cut. I freehand that now with the prosthesis I use, but there are different techniques you can use. We cut the humeral head, then we prepare the canal. The bone's hollow like a soup bone. It's hollow in the center, and the humeral head and ball is fixed to a stem that goes down the center of the canal. We used to cement these in. I press fit these now for a variety of reasons. It's quicker, it's easier. The wound's open less. I think that if a wound is open 2 hours, they probably have a higher infection rate than a wound that's open 90 minutes. So I firmly believe that if you can do surgery well and quickly, that it's probably better for the patient. Also, if they get a problem later, it's easier to take the prosthesis out without destroying their native bone. So those are part of the reasons why I've gone to a press fit technique. And I think most of the shoulder community across America is embracing the press fit technique on the humeral side. We prepare the canal, take off the bone spurs. As I said, we have different head sizes we can select. There's an offset to this, which means you can dial this in properly. We like to see this relationship where the bone is concentric and confluent with the native bone. So we can sort of dial this offset in to get that correct, because the head itself has an eccentric receptacle for the button on the stem. Different pathology requires different techniques. That's my job, not yours. But if you see something funky that in the orders after an operation that says, don't move this, don't rotate this, it's because I encountered or did something differently to this patient. Most of my osteoarthritics, where it's pretty straightforward, I can have you rotate out to 30 degrees and up to 100 degrees or 110 degrees right away. But if for some reason I'm worried about that, I'll dial that back. If it's a fracture case, I won't let you do that. If they have a very patulous posterior capsule, because they had that eccentric erosion like I showed you on CT scan, and when I re-center the joint, the gristle bag on the back of the shoulder is floppy and loose. At surgery, I'll tighten that up. That's a posterior capsular imbrication. That can mean they're in a different brace after surgery, and I won't want you to let their operative hand cross the midline. So you may see these funky, different, and unique instructions post-operatively on each case. We just have to tailor the rehab and the surgery to the pathology. And I love questions from my therapist. If you guys are confused or concerned or have an issue or a question, call me. I would much rather answer too many questions than not enough questions. The glenoid is where I earn my paycheck on the shoulders. It's the hard part of the total shoulder replacement. It's the deep part of the shoulder replacement. It's tougher to expose. That's why early on in the 80s and 90s, people were trying to convince themselves, yeah, it's good enough to do a partial replacement. That works, right? We can just do the partial replacement. But we know the shoulder replaced on both sides has better motion, less pain than the partial. But that's the harder part. You got to expose the glenoid, assess the version. If it's worn to one side more than the other, I have to correct that at surgery. There's some artistry and cabinetry work involved. We have to scrape the bone, drill a center hole, ream it, prepare the slot for acceptance of the cement. We put cement on the glenoid still on total shoulders. On reverses, we don't use cement on the glenoid side. But on regular total shoulders, to get this cup to adhere to the bony glenoid, we insert cement in the bone, then we pressurize it, try to get good cement penetration so that it's immediately well fixed and will last. Once it's inserted, that's what it looks like, a plastic cup. After that, we locate the shoulder, assess stability. We may make some changes at that point based on how loose or tight things are. We could change the head out for a different size. Again, if they have a posterior capsular laxity and I do a imbrication, they may be in that brace that's not a rectangular pillow, but a metal triangle that holds their arm straight out. And I'll ask you not to bring their hand across the midline, because doing this stretches out my repair in the back. I'm talking a lot and I'm just spewing all this information. Are there any questions to this point? Or feel free. This actually should be a two-way exchange, so if you have any questions, feel free to interrupt me. So post-op, you get those patients on the floor that have had the shoulder replacement. I hope the nurses have noticed the difference with the block. Have you? Yeah. Be sure to tell your neighborhood anesthesiologist that you appreciate the block. They used to come up screaming. Now they come up kind of sleepy. And that's true. If they're pain-free and getting narcotics, they can actually lose their ability to respirate. And so you need to kind of keep an eye on that. Make sure they're not too sleepy. Feel free to call the rapid response team if that comes up. Check on the hand. Make sure they're not pinching the skin. Make sure they're not getting a pressure ulcer that they're going to yell at me for later. I typically put a drain in every total shoulder. Can't imagine a situation where I wouldn't. I like to keep antibiotics on while the drain is in. I like to give a dose of antibiotics after the drain comes out. Shoulders don't fall under skip data, so I can use whatever I want, and I do. But there are reasons why I pick what I pick. Cleocin usually covers MRSA, as does Vanco. Cleocin also covers Propionibacterium acne, which is a very common pathogen in shoulder prosthesis infections. It's the bacteria that causes acne. It's also hard to grow in the lab. So what we found is if you get an infected shoulder, you know it's infected. It's infected. You get in there, you operate, it looks infected, you do your swabs, you clean it out, you send it all to the lab. You take everything out, put in a cement spacer. The lab comes back 3 days, no growth. We know now that you need to actually keep those cultures in the lab for 14 days to grow out Propionibacterium acne. So that's one change that we made on doing our infections. I always call the lab and tell them keep them for 14 days and call me every couple of days and let me know what's going on. So typically the drain will come out after the shift drainage is 30 cc's or less. If that happens, we're going to be doing all these order sets for the EMR. I'm going to build that right in. If there's a shift where the drainage is less than 30 cc's, you guys can pull the drain. If for some reason that doesn't occur until 48 hours, I still want you to pull the drain because drains get colonized at 48 hours. And so then it's risk-benefit analysis. Is it better to have a little hematoma or is it better to have bacteria in the wound? And I want to pull the drain out. I always want to do one more dose of Cleocin after the drain comes out. Pain control, typically the block should cover most of it early on. We'll keep PO and IV antibiotics available. It's good to stay ahead of the pain. The nurses have a balancing act on their hand, again, as I said, for keeping them respirating and pink. We like pink. I'm going to start adding Celebrex 200 BID unless they're allergic to sulfa. That also keeps the pain knocked down, and we're going to continue that post-op for a couple weeks. So that'll be something on our new EMR order sets that I'll put in. This is the rehab we try to do after shoulder replacement, the typical one, where there's nothing funky. We'll allow external rotation to 30, active elevation about to 110, 120. So there's no reason to stretch it way high right away. You're just straining those stitches through the subscap that early on. So let things kind of set. Let the healing of the muscles start to share the load, not just the stitches. And we'll get the motion back completely later. Also important with rehab, and we're going to getting OT on board right away as well, right after surgery, is teaching the patient how to get around with just one arm, do activities of daily living. We want the patient to know how to put the sling on and take it off. We want the family member to know how to help them with that. We want them to know they shouldn't get their elbow behind their shoulder for the first couple weeks after surgery. Anytime the humeral head goes opposite the elbow, right? So anytime your elbow's this way, the humeral head's trying to squirt out the front. So we don't really want this position in a fresh total shoulder where the subscap's trying to heal. We want them to be able to get up and walk around. I have some patients that love the bed. They love the bed. They want to stay in the bed. You got to get them up and walk around. You got to get them up and walk around. I think that's an important thing for them feeling normal again, is that I now have the power to get up and walk around. If they can do that, then they will feel more confident about going home. So educate them about those precautions. Pretty much keep the elbow in front of the shoulder. I'm going to routinely initiate home health on all my total shoulders. I just think it's another pair of eyes in the home that can watch, make sure nothing funky is going on. No dog fights in the trailer, nothing like that. Typically these patients will stay one night. Sometimes they'll stay 2 nights. The only reason to stay 3 nights is if they're not going to fly on their own, then they need to stay for the skilled nursing facility. That's a 3-night stay. Again, we kind of exhausted the subscap protection deal. One tip, though, when you're doing your pulleys, we want it done in pronation, not supination. When you're doing your Codmans, we want them done in pronation, not supination. Supination is mainly forearm. But when patients supinate, they also tend to externally rotate their arm, which is further stretching the subscap. It's not a complication-free operation. Complications do occur. 90% good or excellent results. That means 10% are not good or excellent. Okay? Complication rate's about 14%, but most of those complications are transient or reversible, like a hematoma or little wound drainage or a small neuropraxia that will resolve. But some of those complications are big deals, like a shoulder dislocation or late infection. Instability is rare, thank goodness. Most of the instability I've seen after shoulder replacement typically occurs after things like fall out of the tub, fell down the steps, or got into a smack fight at 4 weeks. Pretty much, I try to make sure the shoulder's stable before they leave the OR. Neuropraxias are very rare, very, very rare. But in a series of 18, and this is culled from hundreds of shoulder replacements, 16 resolved at a year. So not only are they rare, but they're also temporary. Infection, I think, is a little bit better than hips and knees. Upper extremity, better vascularity. They just have a little bit of a lower infection rate. I think we're doing really good with infection rate here. Knock on wood, I've had one infection, I think, probably in the last 100 shoulders, and I think that's going to continue to be better as I get more shoulders that aren't getting infected. Most of those are immunocompromised patients. The people that tend to get infected are the people with severe comorbidities. There's papers out there now that show infection rates are higher in people with chronic renal failure, diabetes, COPD, sleep apnea. They just don't do as well. Unfortunately, that's a lot of our patients. Postoperative rotator cuff tears can occur. How can you predict this? You can't. 90% of 90-year-olds have cuff tears. If you live long enough, it's like prostates for guys. If you live long enough, you're going to get a cuff tear. So if you get an MRI at 60 and there's no cuff tear and they have arthritis and you do a regular shoulder replacement, that doesn't make you immune of getting a cuff tear when you're 75. The way that can happen is increased pain, increased loss of active elevation. The problem is they got a big hunk of metal in their shoulder, and we now can't get a good MRI to show whether or not they have a cuff tear there or not. So we kind of milk it along, and when it gets bad enough, we can do an open exploration and consider converting them to a reverse. So far, there are very few takers for that. It's a big operation, and most people will live with a little bit of inability to raise their arm up if they get a small cuff tear 8 years after their shoulder replacement. Intraoperative fractures, I have had one glenoid fracture early on in my reverse career when I was reaming the glenoid. Instrumentation has improved now. We have hand reamers. It's not done with a lot of torque or power, so it's a lot safer. We haven't had fractures intraoperatively in a long time. Post-op infection prophylaxis, if people are getting teeth pulled, they have gingivitis or whatever, they're going to the dentist, I recommend they take oral antibiotics just like as recommended for hips and knees for a couple years after the replacement. Humeral loosening can occur in press-fit humeri. This is older studies, older technique. The curious thing about the humerus loosening is that it's usually not symptomatic. So you see a dark line on x-ray, but the patient's happy. In this series, even at 12 years, no patients came for revision surgery because of a loose humerus. Glenoids can loosen later. Radiolucent lines just means you get an x-ray and there's a dark line next to the cement. That's not the same as rolling your arm around and feeling click, clunk, click, clunk. So radiolucent lines has a high percentage, but that doesn't usually mean the glenoid itself is loose. And curiously too, even if glenoids are definitely loose, which in Cofield's series at 12 years, almost 2/5 were loose, the ache that they had was usually not enough to warrant in the patient's mind a revision operation, and they can still have pretty good function as well. Shoulders, again, like I said, they last a long time, 87% at 15 years. Correction, 84% at 15 years. Humeral head replacements don't last quite as long. Part of that, I think, is because we're typically putting them in younger patients with higher demands. But there's some thought that maybe doing the regular full shoulder replacement, even in a younger patient, might even be protective compared to just doing a hemiarthroplasty. Late rehabilitation at the 3-month mark, we're going to do more strengthening, more stretching. They can do recreational activities, swimming, golf, social tennis. I tell my patients it's not made for chopping down trees, digging ditches, or wrestling bears. Ever since I had that patient who was a bear wrestler and had a dislocation. No, I'm just kidding. So we're about at the end here. I think shoulder replacement is a great operation in the right patient. There's a lot of patient selection involved. I think we're in a bit of a tough geographic location. A lot of our patients are very sick. Anesthesiology will tell you a lot of our patients have a lot of comorbidities, as much or more so than they see in Charlotte. So it makes it challenging at times. Coupled with that, our patients' education level is not quite as much as it would be in Charlotte or a metropolitan area. So we have to watch them closer and educate them a little bit more. But in general, it's a great operation. It provides relatively permanent gains in pain relief, permanent gains in motion and function. Osteoarthritis and atraumatic AVN patients do best. Results do relate back to the underlying pathology. Rheumatoids with poor cuffs will have less active elevation than your 50-year-old with osteoarthritis and a robust cuff. The results do reasonably well for younger patients, but they're not made for younger patients. They don't last as long in younger patients, and results tend to deteriorate when you put them in 44-year-old moped drivers versus 65-year-old osteoarthritis. Hope I've given you a broad perspective like we had this summer when we went to Zion National Park. Any questions?
How vigorous can a person be, let's say, a year post just a regular total shoulder? You're saying no bear wrestling or anything, but
I would expect them to be able to garden. They could use a shovel to dig dirt, loose dirt. But if they're using a mattock to dig out roots and stumps, that's probably not good. They can play doubles tennis, old person's doubles tennis, not Venus Williams doubles tennis. They can exercise with light weights. I would expect them, if they're going to use weights, to keep it at sort of the 5 to 10 pound mark. You get these patients with a crazed look in their eye, like they want to be 20 again. And I sympathize, but none of us are going to be 20 again. If you're 20 now, enjoy it. But, you have to have a realistic approach. You have to have a realistic approach. And you guys do a great job. You do have a realistic approach, and I think you do a great job of watching my patients and getting back to me if there's a problem. I do appreciate that. If there's anything that you want me to be aware of, please don't put it in a note. You can put it in a note, but don't assume that I've read that. If there's something you want me to be aware of, just call me up. Yes, ma'am.
Have you considered the use of cryotherapy after total shoulders, like a cryo cup or something like that we could use immediately post-op here in the hospital, and then that could continue with them at home?
Sure, I'm open to that. We could try that.
I noticed, not so much with the shoulders, but maybe like with the knees and stuff, I think that would probably be beneficial, but I would assume that it would probably be beneficial on the shoulder.
The knee's ideal. It's a subcutaneous joint. It's not surrounded by a lot of other mass usually, and you can wrap something around it easily. The shoulder's a little bit tougher, but I do use cryo and CPM machines on my arthroscopic cuff repairs and other shoulder repairs that aren't prostheses. I don't use the CPM in a total shoulder because I'm worried that the machine itself would dislocate the shoulder if someone got in a funky position and just trusted the machine. But cryo's not unreasonable. We can certainly try it. We have a nice dressing we use now that's water resistant. It's kind of rubberized and has silver impregnated gauze next to the skin, so it's fairly thin and not bulky. And if we were to use cryo, I would want a thin piece of cloth or material between the patient's skin and the cryo so they wouldn't get frostbite on the skin. But yeah, I think we could try it. I'm happy to try that and see if you guys think it helps, and ask the patients if they think it helps. I'm willing to do anything that doesn't involve me filling out a lot of forms. So, any other thoughts or questions? This was a lot of information. I went over a lot of things that we can do with shoulders. I hope I touched on the things that concern you guys as therapists and nurses. And I want to make sure you guys are involved when we develop the electronic medical record order sets. I want everyone to make sure that they have their input, because I only want to do it one time. So, all right. I appreciate it. Thank you.